So this was, you saw the clinical case scenario, and we had, again, to summarize, we had the 17-year-old patient initially requiring steroids, then transitioned to appropriate therapy, doing well initially on combination treatment with azathioprine. She swears she's been taking it, a biologic agent, doing well, but now has a relapse or a flare in her symptoms. No recent travel, nothing different, nothing new. So we asked our audience, what would they recommend? What would you recommend, Dr. Vallejos? What would you recommend in this situation? Microphones in the back.
So this is, to me, it looks like a classic secondary loss of response. So by that I mean it's basically a patient who was on treatment, she responded to it, and at some point she loses response. And so here, I think answer E, all I can see are all reasonable. The question is really what order do you do? And so I think that for somebody hello, for somebody who flares, for somebody who flares, I think the first thing you do is you check C. diff, and I would check a anti-TNF drug concentration and antibody. And the main reason why is that it's always important to get very objective findings, but at the same time you have to kind of look at it. Although it's nice to do recreational colonoscopy, the fact of the matter is that if it's possible to, if it looks like a duck and acts like a duck, I think we can do it. I mean, so in this case, if C. diff and infection has been ruled out, there's elevation in inflammatory markers such as CRP. And in this situation, for example, if you have a low drug concentration, just to kind of create, there's a couple of scenarios where we would do more objective measurements, but let's say that there's an obvious mechanism like a low drug concentration or a high antibody. Then I think you can just reasonably assume you understand the mechanism and make the switch. Now, where I would reserve doing the colonoscopy is that if there is a therapeutic drug concentration, so meaning that we think that it's not a drug issue and no antibodies, that's in where I would then try to be more objective and potentially do an MRI or a colonoscopy and just kind of make sure that there is really active disease before I make that switch.
So Dr. Vallejos is suggesting that first we should rule out infection as well as check drug levels and antibody levels. But Dr. Vallejos, the patient says, but I'm dealing with this for so long. How long until you get these levels back will you make a decision for me?
So I think that's where, usually the drug levels come back in about a week. And the reality is that this is a condition where the practical nature of it is between authorizations. This is something where even when you're trying to make fast decisions, it's not like it's not like a door to balloon time. We're not really just doing all of these changes usually occur over a 2 week. But I think 2 weeks is better than a month,
right? Which
is better than 6 weeks. So I think that I would say if somebody's that sick, then you may need to bridge them or potentially from there even hospitalize them. So I would say that if they're that ill, it's either steroids or hospitalization. Okay. If that 2 week window is not
I think what you're trying to highlight here is we don't want to just make big decisions, change therapy right away, lose another therapy that they're currently on if they have an infection or if they just need to be dosed up in that particular biologic agent. Dr. Wabe?
I'd love to hear maybe more of your thoughts about this from my adult colleagues. So the scenario is patient week 6 from her last infusion who is now breaking through, no travel, C. diff negative, you get C. diff results within an hour. I wonder, many questions come up. One is, are the levels validated at week 6? And we know from what we learned from Neil's talk is that the pharmacokinetics may indicate that the last 2 or 3 weeks are the bigger drops in the level. So we're using a level at week 6 to predict or plan what we're going to do next. And I have to say, a wait of 2 weeks is a very, very long time before we make adjustments. So I would counter that to say that regardless of the level, if your patient breaks through at week 6, you want to bail that patient out and infusing earlier with maybe more of the drug and then reassessing with the next infusion at 8 weeks might be, in my opinion, maybe a more practical approach. I'd love to hear your thoughts about that.
I mean, I think all of these are, I mean, some of this really just depends on the patient in front of you. I mean, there could be a flare, it's, a flare with a small f or a big F in terms of how sick somebody is. I think, though, the concept of just switching therapies, so we ended up doing a decision analysis looking at whether you just essentially, for example, if you dose escalate, you presume always 100% of the time that the main mechanism for loss of response is going to be a subtherapeutic drug concentration, which is not always true. And so in this decision analysis that we did, we kind of created these two cohorts of one group where you would essentially first dose escalate, then change to a different biologic, then go to a different mechanism of surgery, as opposed to doing therapeutic drug monitoring, and then based on the findings, similar to what Dr. Van de Castile showed, would make the appropriate treatment. And after 1 year, you see that the patients who are in remission and in response is exactly the same, but how they got there is quite different. So if you essentially do where you get therapeutic drug monitoring and decide, what you find is that more patients do end up going to surgery, and also you use much less high-dose anti-TNF therapy. So the thought is that even though, kind of to your point where you said, it's in remission, but it looks differently between enteral nutrition and TNF, the fact of the matter is that, we think, or at least the reason why I practice this way, is that I think that that's kind of better medicine, and that I'm actually diagnosing the issue more appropriately. You can debate whether it's, if you're just going to give everybody high dose and then switch them later. I guess there's certain practicality to that at some point. I mean, you're treating the patient in front of you, but I think ultimately that means you're always going to give somebody extra medication before putting them on another TNF. So I would rather usually just bridge them with a course of steroids if it's required. But I will say obviously that sometimes if a patient is not doing well, I mean, and it looks like it's going to be a while, you'll just give them the dose you just give them the medication that's already been approved. I mean, so that's more practical as opposed to, academic, I guess, way of thinking about it.
Dr. Van Castile, any harm in let's say, as Dr. Wabe said, we're waiting till week 6, seeing how they're responding. Any harm in giving them extra 5 mg per kg on top of the prior 5 mg per kg that they received of infliximab, let's say, for example?
I don't think there's really harm for that approach. I think the most of the infusion reactions that are typically seen for infliximab at least are early on, like week 2 infusion, typically when a patient is reintroduced after a drug holiday. So I don't think from an adverse event point of view that there would be any harm in giving the dose at week 6 already. And I definitely agree that it's a great time point, however, to take that sample and to measure drug concentrations and anti-drug antibody concentrations at week 6, just before you give the next dose, because that will help you in, let's say, determining what the next steps will be in that patient.
So I think the take-home message there is therapeutic drug monitoring. We've entered this unique era where it's very important to do TDM. Know what your drug level is, know what your antibody levels are, and particularly in folks who have been very sick initially and you had to start, for example, an agent such as infliximab, drug level monitoring, particularly at week 6, will help you move forward knowing what your decision should be after that. Meaning, specifically, one size doesn't fit all. We went with this 5 mg per kg strategy, but absolutely there's the PK for certain reasons will be different among patients, and their ability to absorb and have that infliximab, for example, work can vary as well. Dr. Lee, any additional thoughts on that?
Before, I just wanted to add one, because I heard one thing that just to make sure I understood the question. It might be a subtlety, but in this patient, I think she had a loss of response somewhere along the course, which I would say is a little bit different, which maybe is what you were hinting at, and I don't know, which is the patient who, will have kind of like a slow creep, which is that you go from every 8 weeks to symptoms every 7 to every 6. I think there you can pretty safely assume that, I mean, I think you still check a drug level, but you can usually just respond there. with a higher dose, because I think that is a much more normal sense. I mean, it's probably the most likely. So in that secondary loss of response, there's that creep, which I think is possible, but then there are other patients who just somewhere in the middle, they just flare. And I think that's where I would kind of just do the drug
Further
monitoring before
evaluation.
making a decision.
Nothing to add.
Let's put up the next question.
While they're doing
Is this the next one?
Hello. You had mentioned maybe the patients with the creep, it's not unreasonable to dose them, but you still would check a therapeutic drug level. So say they said, yeah, I went from week 8 to week 7 to week 6, or for the injectables, I went from 14 days to 10 to 9. If you get the level, is it changing what you're adjusting? Meaning, I went from 5 mg per kg to 10 mg per kg, or would you go, you're just below, so I'll go 5 to 7.5. And maybe Niels can comment on when we get these levels, how do we adjust with them? Pharmacokinetics, pharmacodynamics.
So I think Niels will give more of the scientific part. I'll give more of the just kind of the clinical aspect, which is that I think it's still helpful. I can't say I do it 100%, but I think it is still helpful because there you will be able to distinguish whether you're starting to already develop antibodies or not. In which case, even though at the end of the day you may still continue the patient on that dose, depending on how they got there, you may decide to add an immunomodulator, you may decide to do more frequent therapeutic drug monitoring. So I think it will change your management, even though obviously you've already made a decision, you've already made a commitment to give a patient a higher dose.
Yeah, and I just want to comment on the, let's say, decreasing the interval versus increasing the dose. What you should do in setting of secondary loss of response. So there is some retrospective data looking at both types of interventions, and there's no clear benefit for either, or let's say they're similarly, let's say, efficacious. However, there are a few things you can take in mind, let's say, because from a PK perspective, you'll end up with the same effect. So if you decrease your interval by 2 weeks, that's about 1 half-life of drug for infliximab. So you will, if you're treating to trough, you can assume that your trough will be about twice as high. Whereas if you double dose and go from 5 to 10 mg per kg and let's say keep the interval constant, then you can have the same theoretical expectation that your trough concentration is going to be twice as high. However, if you look at the area under the curve, so the drug that the patient has been exposed to is much higher for the 10 mg per kg. You will have a much higher peak concentration. You will have more area under the curve compared to the patients where you have decreased the interval between infusions. So if your goal is really to treat to trough, then let's say decreasing the interval will be a more cost-efficient approach. Whereas if you, and I can definitely imagine in some situations that that's preferable, if your patient presents with a severe flare, maybe you do want to reach a high peak concentration and expose that patient to a higher load of drug and go for the double dose instead of the shortened interval.
Okay, so really not much difference between increasing dose or shortening the frequency of your treatment of your biologic or increasing the dose when you're talking about outcomes, efficacy outcomes in regards to that. But certainly if you're targeting specifically to give more drug, it sounds like based on PK studies that Dr. Van Castile is describing, definitely an improvement with a higher dose to achieve better efficacy in that level.